This is Dr. Gardner, and this lecture is on adolescent alcohol and substance abuse for nursing 592 and 692. Substance use and abuse by adolescents remain critical problems because of the common use of psychoactive substances by youth, the ensuing consequences, and the persistence into adulthood of pathology related to substance use. Clinicians should consider neurobiology, all aspects of development, and characteristics of the individual adolescent. Treatment should focus on specific substance use behaviors, risk factors, and the inclusion of family. This lecture will encompass everything you really need to know about adolescence and substance abuse, alcohol abuse, and I am going to include gambling and internet addiction. So let's talk about the reward pathway and the effects of drugs on the dopamine pathway. Addiction is a neurological disorder that affects the reward system in the brain. In a healthy person, the reward system reinforces important behaviors that are essential for survival. However, drug abuse hijacks the reward system. So things like feeding, sexual activity, and social intervention is no longer the same kind of reward for someone who's using drugs. Most drugs of abuse increase the level of dopamine in the reward pathway. So again, drug abuse hijacks the reward system and turns a person's natural needs into drug needs. Drugs like alcohol, heroin, and nicotine indirectly excite the dopamine-producing neurons in the ventral tegmental segue. So they generate more action potential. So let's talk about the pathways. Cocaine acts as the nerve terminal. It binds to the dopamine transporter and blocks the reuptake of dopamine. Methamphetamine, which is a psychostimulant, acts similar to cocaine in blocking dopamine removal. Different drugs act in different ways, but the common outcome is that dopamine builds up in the synapse to a much greater extent than normal, resulting in prolonged and intense euphoria experienced by the drug users. The repeated exposure of dopamine surges caused by drugs eventually desensitizes the reward system. The system is no longer responds to everyday stimuli. The only thing that is rewarding is the drug. Eventually, the drug at the current dose is no longer rewarding, so greater amounts are needed for the reward feeling, which leads to drug overdose. So when we talk about adolescence and substance use, the leading cause of death among teens, the use of illicit substances, is associated with the leading death among teens. Studies have found that 46% of adolescents have tried alcohol by 8th grade, and by senior year, 77% of adolescents have begun to drink. So the prevalence, there's an increase in availability and decrease in perceived risk of harm. The increased usage is attributed to an increase in availability, especially in states where marijuana is being decriminalized and legalized. Teens do not perceive a risk of harm associated with drug use. They don't believe that anything bad will happen to them, but it might happen to someone else. The typical drug user, what does that look like? Well, the typical user is a white male in a middle to upper middle class family. Some of the risk factors, and I'm going to touch on risk factors more than once, but let's start with this slide. Risk factors include a family history of substance use, abuse, or mood disorders, poor parental supervision, low academic achievement, untreated ADD or ADHD, perceived peer acceptance, youth with chronic painful medical conditions, acute or prolonged injuries, or multiple medical or dental procedures may be at risk for developing an addiction to prescription opioid pain medications. As the psychiatric mental health nurse practitioner, you should evaluate children and adolescents for drug use. Most teens surveyed reported not telling providers about their usage simply because they weren't asked. So we need to make it a point to ask teens openly about their drug use. So when you evaluate for drug use and abuse, ask open-ended questions. Questions like, have you ever had an alcoholic drink? Have you ever used marijuana or any other drug to get high? Ensure that when you're asking the teen these questions that you are providing a confidential environment. Most teens will not answer truthfully with a parent in the room. You also need to establish a trusting relationship. If they don't trust you, they're not going to answer honestly. So, substance use in young children. So, children as young as 3 to 5 years old may present with behavioral dysregulation symptoms like impulsivity, aggression, hyperactivity, inattention, poor persistence, or emotional lability. And that's because they may be subjected to some form of substance abuse. I read an article recently where a adult has been sentenced. Actually, he's in jail. He hasn't been sentenced yet, but he was doing drugs with his 13-year-old son. So that's a case where the parent and son doing drugs together. But several cases in Louisiana over the last couple of years involve young children having access to drugs because there's drugs in the home. So don't count out these younger children. Behavioral dysregulation is pretty much a constellation of symptoms. So what are some of the screening tools? And we will go into depth a little bit later, but some of the screening tools that you can use, craft. And if you use craft, if it's positive, follow up with a comprehensive assessment. Like, how old were you when you first used? How often do you use? Have you had any legal problems associated with drug use? And what kind of impact has it had on your social, work, or school? The craft study is asking things about the car, relaxation. Are you using it when you're driving? Do you use it to relax? Do you use it alone? Have you ever forgotten something important because you've been using? What about, have you gotten into any trouble? Are you using this with a family or a friend? Some of the screening questions you should consider. Have you ever regretted something that happened when you were using drugs or alcohol? Do your parents know about your use? And what's the worst thing that ever happened to you while using drugs or alcohol? Another screening tool would be screening, brief intervention, and referral to treatment, which is also called the SBIRT. And that is screening for cigarette use, alcohol use, substance use, and risky behaviors. There's also the screen to brief intervention, or the S2BI. It's a brief series of questions, and those correspond to the DSM-5 diagnoses for substance use disorder. Some of the interventions we can use for substance use, for abstinence: positive reinforcement, anticipatory guidance. We want to educate, and we definitely want to give positive reinforcement to that teen that is not using. If they're experimenting, educate them about the risks, and don't take for granted that they know about all the risks associated with different substances. So that's a time to educate. For non-problematic use, risk reduction advice. And what do I mean by non-problematic use? Because of course, using drugs is problematic. But if they haven't gotten arrested, if they haven't had any injuries, if they hadn't had any problems at school or work, start giving them some risk reduction advice. If there are problems, do brief interventions. And I'll talk about brief intervention shortly. But that includes like feedback, education, negotiation. Once they've gotten to abuse, you want to refer them for counseling and definitely follow up, and again, brief intervention. If they're at the state of dependence, well, referral to an intensive residential treatment program is the best option. Secondary abstinence, after they've been using and now they're abstaining, positive reinforcement. Again, positive reinforcement, support, and follow up. So some of those brief interventions that I was talking about: feedback, education, recommendations, agreement. So have a client-patient agreement and definitely follow up. So when you talk about comprehensive assessment, first you want to do the comprehensive evaluation. So comprehensive assessment is a thorough process. It includes variables or factors contributing to and maintaining substance use, the severity of the problems, and the variety of consequences associated with the adolescent's behavior. So you look at substance use behaviors. The assessment process is used to identify individuals who have substance use disorder and whether they meet the criteria for the DSM-5 substance use disorder diagnosis. So we want to look at any psychiatric or behavioral problems. The pattern of use and any consequences of use are also discussed. The results of the comprehensive assessment usually identify individuals who require treatment, what level of treatment is needed, and other problems, as well as the strengths of the adolescent. So we want to look at their school and occupational functioning. How are they doing in school? Are they getting in trouble? Are they failing? If they have a job as a teen, have they gotten fired? Have they had any disciplinary action? What about the family functioning and family dynamics? Are there problems in the family associated with drug use? And what about their social competency and peer relations? How are all of these affecting this adolescent's functioning? We also want to talk about their leisure and recreation. Are they still doing things that they were doing before, or have they given that up because mainly, of course, that dopamine pathway, the reward system's been hijacked, so they no longer play video games. They no longer hang out with their friends. All they're pretty much doing is looking for their next high. So when you're doing your interview, you want to do a comprehensive substance use history. What age did they begin using? How long? What about the frequency? Route of ingestion for each individual drug, like alcohol, tobacco, illicit drugs, inhalants, any over-the-counter medications like sports supplements or something that they can purchase online, even prescription drugs like benzodiazepines, opiates, and stimulants. Have they had any negative consequences? Have they made any attempts to quit? Um, what about their motivation to control the drug use or quit? That's important to know in your interview. Also, the settings of use. Where are they using it? When are they using this at school, after school, in the home, at a friend's house, parking lot, the time and the place? Are they using these alone or are they using it with peers? Other things you want to do in your interview, screening questions about depression, suicidality, aggression, psychosis, and treatment history. That may be sufficient to augment other information in determining when an adolescent should be referred for more detailed, comprehensive psychiatric evaluations. Clinicians should use medical history and possible physical examination to search for symptoms and illnesses that may be related to substance use disorders and behaviors, including trauma, pregnancy, HIV and AIDS, and other sexually transmitted diseases, infections or wounds, and possible liver disease. Now, I want to go back to remind you that you will need to know assessment. So understand different aspects from nursing 507 or 607 to determine if it's medical, mental, or substance abuse. And this is the exam where you will start seeing some assessment questions because assessment questions will be on your certification exam. So I will start to incorporate assessment questions on exam 3 and exam 4. So again, you should be able to use the medical history and possible physical exam to search for other symptoms of illnesses that could be related to substance use disorder. So assessment questions, interview questions are important for you starting with this exam, exam 3. You need to remember and brush up on your assessment. Confidentiality is important. So we talk about the Health Insurance Portability and Accountability Act, or HIPAA. Both HIPAA and state laws in most states protect confidential information in adolescents that may provide during treatment. Adolescents are more likely to provide truthful information if they believe that their information will not be shared. So as a provider, you need to review what information can be shared and will not be shared. Before the interview, discuss which information you're obliged to share and with whom. Typically inform the adolescent the threat of danger to themselves or others, or information about physical or sexual abuse will force you to reveal otherwise confidential information. Be honest. When you're forming that therapeutic alliance, you have to be honest with them up front. Also, know your state and federal laws. Be knowledgeable about them because some state and federal laws limit what information may be released from drug and alcohol treatment programs, and that's something that you need to know. The confidentiality statutes regarding illegal behaviors. So confidentiality statutes include information about illegal behaviors such as selling drugs, who sells to the adolescent, like who's their plug or who's their supplier. and peer behaviors. Consent. Before the treatment team can speak with the adolescent's family, school, or legal staff members, the adolescent must sign a consent form. In some states, the parent must also sign a consent form. So you need to know rules regarding your state. For example, in Louisiana, the age of consent for them to come and get treatment is 16. In Washington, it's 13. So a 13-year-old can come in, get treatment, and guess what? You cannot talk to that parent without the consent of that 13-year-old. Same way if you're treating a 16-year-old, you can't just go talk to that parent without getting consent from that 16-year-old. So what that 16-year-old is talking to you about is confidential. But as a clinician, you should encourage the adolescent to reveal to their parents the extent of their substance use and other problems. You can't force them, but it is good if you encourage them to talk to their parents about it. Toxicology. Okay, so let's talk about when we have to test any bodily fluids like urine or saliva. We test body fluids and hair samples to detect the presence of specific substances. That should be a part of your formal evaluation in the ongoing assessment of substance use. Before testing, you should establish rules in the confidentiality of the results. And remember, negative screens don't indicate that the youth does not use drugs because urine drug screening has different time frames. So within 1 to 2 days for amphetamines and stimulants, they'll show up in a urine drug screen if they've used. 1 to 4 days for opiates. THC and cannabis can show up anywhere from day 1 to over 30 days. So you can get cannabis use at any time. So when you're testing, remember, you may get a negative drug screen, but that doesn't mean that that adolescent is not using drugs. So some of the treatment options that we look at would be behavioral therapies, pharmacotherapies, which they're not often used in adolescents, but we will talk about them a little bit later in the lecture, and 12-step programs. Some of the inpatient treatment could be like detox, it's a couple days, rehab is a couple weeks, or they may need some long-term residential treatment. I want to go a little bit into epidemiology. So when we look in the United States, about 12.5% of the youth in the U.S. use marijuana, 0.4% are using cocaine, 2.7% are using inhalants. There's about 1.5 to 2.8% that are using prescription drugs, and about 0.1% of youth in the U.S. are using heroin. You will not have specific test questions on epidemiology, but it is always good to know what you're dealing with and the amount of the population that you're dealing with. For gambling and internet addiction, about 60 to 80% of adolescents engaged in some kind of gambling. And that is not 709, that is a typo, I apologize. That's about 7.9 to 25%, 25.2% of adolescents reported gambling. And again, you won't be tested on this, and I apologize for that typo. So let's talk about comorbidities. So psychiatric and substance use disorder, comorbidity is the rule. Onset of comorbid psychopathology may precede, exacerbate, or follow the onset of heavy substance use. A review of adolescent community surveys found that childhood mental illness, particularly conduct disorders, generally predict earlier initiation of substance use and substance use disorder onset. So about 64 to 88% of adolescents with substance use disorder have one or more comorbid psychiatric diagnoses. Adolescents with internalizing disorders tend to be more engaged in treatment and less likely to relapse. So half of the adolescents in treatment centers have 3 or more comorbid conditions. And conduct problems like ADHD, mood disorders, and trauma-related disorders are related to substance use disorders. So in general, the presence of a psychiatric disorder predicts earlier age at onset of use in substance use disorder, more rapid progression of use to substance use disorder, greater substance use disorder severity, and more persistent substance use disorder. There is a fourfold increased risk for disruptive behavior disorders in youth using and abusing substances. And of treatment-seeking adolescents, 44% have undiagnosed or untreated ADHD. And one study suggests that bipolar disorder during adolescence is a risk factor for subsequent development of substance use, and that adolescents with comorbid bipolar disorder and substance use disorder have significant functional impairment and higher suicide risk. So we talked about risk factors before, and again, here's some more curiosity. Using e-cigarettes, their environment, maybe a genetic disposition, how old they were when they first used, or if they're using alcohol, cannabis, or cigarettes. Those are all risk factors for substance use disorder. Okay, so curiosity. They want to know what their friends are doing. Their friends are getting high and talking about this euphoria, so they're tempted to try it as well. They start with alcohol, maybe some weed, maybe cigarettes or e-cigarettes, exposes them to the possibility that they may increase to substance use disorder. Their environment. Maybe they live with parents who are using, maybe aunts or uncles around them are using. Maybe they're from a low socioeconomic status where they see it often. Again, they may have a genetic predisposition. So let's start talking about some of the substances that you need to know. You need to know what they look like, and you need to know some of the effects of these substances. We'll start off with cocaine. Cocaine is a white powdery substance. It's either smoked or snorted. Patients may have dilated pupils, weight loss. They may have a hoarse voice, an inability to sleep, or they may have all of this abundant energy after they use cocaine. With heroin, they may get a euphoria. They may have a drowsiness. They may have impaired mental function or slowed movement. You may detect needle marks in their skin. And that could be in their fingers, arms, toes. You may see the development of boils, unexplained boils from the infections from their needles. If someone has a heroin overdose, you can expect them to have extremely small pupils, clammy skin, and shallowed breathing. All right, let's talk about methamphetamine. It's addictive, highly addictive. These patients may show violent behavior. They may be aggressive. They may have signs of psychosis. Some of the complications from methamphetamine include stroke, heart attack, HIV, and hepatitis. They may have long-lasting damage to the brain, or they may experience this extreme crash once it wears off. So they're high, and then they're out for days because of that crash. Alcohol. Let's talk about alcohol. That is the most commonly abused substance by adolescents. They experience school problems, such as higher rates of absences or lower grades. They may have social problems like fighting or lack of participation in youth activities. They may have legal problems, such as being arrested for driving or physically hurting someone while they're drunk. They may have physical problems like hangovers or illnesses from alcohol use. They may experience unwanted, unplanned, or unprotected sexual activity. There may be a disruption of normal growth or sexual development. They may experience physical and sexual violence. They have an increased risk of suicide and homicide. There may be some alcohol-related motor vehicle crashes or other unintentional injuries like burns, falls, or drowning. They may have memory problems. Because they're misusing alcohol, they may begin to misuse other substances. They have changes in brain development that may have lifelong effects. They may experience alcohol poisoning. That's big, especially on college campuses. Let's talk about now marijuana. So, there's an increased use among high school students. Marijuana use among high school students is on the rise. And this may be due to the growing national acceptance and legalization of marijuana in many states. Recreational cannabis use has been legalized in 17 states, the District of Columbia, the Northern Mariana Islands, and Guam. And another 13 states in the U.S. Virgin Islands have decriminalized the use. So, legalization has prompted concerns about the use of cannabis. The initiation of cannabis by adolescents aged 12 to 17 increased from 2002 to 2016 with an average of 3,300 daily initiates. That's a lot of people starting to use marijuana. So, students don't see the harm in it. It's legal and it's decriminalized, so the perceived risk of using cannabis by youth in all grades has substantially declined. High school students don't see harm in regular use of marijuana, and it's concerning considering regular use during adolescence. They're undergoing rapid brain development, and marijuana increases the risk of psychosis, reduction in IQ, and persistent neurocognitive defects that may not be fully reversible. However, these young, believed to be invincible adolescents don't quite grasp that. They may experience psychosis, poor academic achievement. They have a greater risk of being a high school dropout and a greater risk of unemployment. So, those are some of the substances that you do need to be familiar with for the exam as far as side effects, what it looks like, what to look for, different problems with neurocognitive development. You need to be aware of all of that. So let's talk about treatment. Of course, abstinence. That is the goal. That is 100% safe if they abstain. However, even though the primary goal is abstinence from substance use, you're not always going to achieve that. So another acceptable outcome would be harm reduction. Let's make sure they're not going to harm themselves or anybody else. Also, an improvement in functioning. So some of the pharmacologic treatments would be treating the comorbid disorders, which from your comprehensive psyche eval, you will determine if they have any comorbid disorders, substitution therapies, detoxification, some blocking therapies, craving reduction, and aversion therapy. And we will go over these. Okay, so substitution therapy. That's used to prevent withdrawal, eliminate cravings, and block euphoric effects of illicit opioid use. So use of an agonist like nicotine replacement therapy for nicotine dependence. Methadone is used for opioid dependence. Or a partial agonist like buprenorphine for opioid dependence. And that acts on the same receptors that mediate the psychotropic effects of a substance. So that is some substitution therapy. Some detoxification strategies. They generally use agonists or medications that provide symptomatic relief. Clonidine is effective for opioid withdrawal. Benzodiazepines are effective for alcohol withdrawal. So those are medications you can prescribe for the symptoms of detoxification because some patients don't want the pain and suffering of detox, so they don't want to give up the substance. They've tried to quit before. Detox is horrible. So if we can give them something to help with those withdrawal symptoms, they're more likely to be prone to go through some kind of detox. Aversion interventions, such as antabuse, that's a blocking agent like naltrexone. Anti-craving medications, that would be like naltrexone, and camprosate and Zofran for alcohol. Bupropion is used for nicotine, buprenorphine for opioids. But remember, for aversion interventions, that requires medication adherence. And these are most useful for patients who are highly motivated and want to quit. Of note, currently there are no FDA-approved pharmacologic agents for youth younger than 18 years old for nicotine dependence. However, the American Academy of Pediatrics recommends that pharmacological interventions should be offered to youth who want treatment. So more treatment options would be psychotherapeutic treatments like individual therapy, group therapy, family therapy, CBT, motivational interviewing, teen intervene, or 12-step programs, or multisystemic therapy. All of these are also effective for treatment, non-pharmacotherapeutic treatment. Lastly, we'll talk about treatment for gambling and internet addiction. So there are no studies that really tell what would be beneficial. However, we all know CBT, family intervention, counseling programs, these will offer some sort of success to a teen who wants help with gambling and internet addiction. Mindful interviewing and motivational enhancement therapy are also used for treatment in gambling. Okay, that is it for substance use and abuse. treatment for gambling and internet addiction of teens. If you have any questions, please let me know.